Today, I would like to talk about the IVUS-guided PCI for complex coronary artery disease. The first thing is clinical evidence regarding the IVUS-guided complex PCI. The first study was the CTO IVUS trial. This was the prospective multicenter RCT. Is a total of 467 patients with a CTO. Finally, 402 patients enrolled, and then divided into two groups: IVUS-guided versus angiography-guided group. And we performed a 12 months clinical follow-up. So, as you can see, the primary endpoint is cardiac death, MI, stent thrombosis, or TVR rate is IVUS-guided group significantly lower as compared to the angiography-guided group. Especially is the occurrence of cardiac death or MI also significantly lower. There was no case with the death or MI in the IVUS-guided group. That there was a statistically significant difference. So what about the diffuse lung lesion? This is the IVUS-XPR trial. A total 1,400 patients were randomly assigned into the IVUS guidance versus angiography guidance. So the occurrence of the primary endpoint MACE rate was significantly different. Angio-guided group was 5.8% versus IVUS-guided group 2.9%. So mainly it's the occurrence of the TRR is significantly lower than significantly associated with the IVUS-guided superiority. So recently, we published the data long-term outcome of IVUS-guided PCI is IVUS-XPR group with 3 or 5 months, 5 years follow-ups, including the ultimate the study. This too is RCT of the comparing the IVUS guidance and angiography guidance. So with the longer follow-up is a statistical significant difference of the 1 year primary endpoint is accentuated and graduated is by the longer follow-up is definitely is the IVUS guided group showed the superior long-term outcome. So what about the bifurcation and left main? Even though there was no RCT performing the for the bifurcation lesions in the registry, especially Korean registry is COBIS, and the main compare registry it showed the IVUS-guided group showed a superior clinical outcome. And also, the Shaolin Chan performed the RCT comparing the IVUS-guided, angio-guided in the two-stent techniques. So definitely, stent thrombosis rate is significantly lower is the IVUS-guided group. So maybe everybody can know definitely the stent optimization would be the most important. So we investigated the role of stent optimization. So how to improve the clinical outcome in complex lesion? The previous CTO IVUS and IVUS-XPR studies, when you look at the outcome of the QCA outcome, is definitely the instance of high pressure post-stent dilation is significantly higher IVUS-guided group, and also the maximal pressure also greater. So these two study is CTO IVUS and XPR IVUS is QCA data is quite similar. So if that imaging guidance, such as IVUS, is always guaranteed the successful outcomes from the XPR IVUS study, patient not meeting the IVUS criteria for optimization group showed a significantly higher MACE rate. It's kind of similar of the angio-guided group. So, and also this is the 3-year follow-up of the XPR IVUS and ultimate trial. So when you look at the comparison of the non-meeting IVUS criteria versus meeting IVUS criteria, so including the TRRs, the hard endpoint, the cardiac death or composite death, MI stent thrombosis, also significantly higher patient non-meeting IVUS optimization criteria. So IVUS optimization criteria would be the most important one. So imaging guidance, obtaining stent optimization would be the key for the better outcomes after PCI of the complex lesion. Everybody knows we can evaluate the pre-stent and post-stent. from the pre-stent evaluation, precise lesion evaluation, especially determining the angiographic configuration, and also we can decide the stent strategy. After stenting, we evaluated the carina or plaque shifting, and also stent expansion and opposition can be evaluated. And finally, it can detect the complications associated with the stent. So what about the clinical outcome of the stent optimization? This study was the previous 4 randomized and comparing the IVUS versus angiographic guided groups. So a total of the 1,396 patients with IVUS-guided group into the according to the stent optimization criteria like this, and divided into 2 groups. And also we compare the clinical outcomes. So definitely the patient with the stent optimization group showed a significantly lower MACE or the composite cardiac death, MI, or stent thrombosis rate. So if that in complex lesions, these are definitely the lesion with the complex lesions. So what's the best combination of the absolute and relative expansion predicting MACE? So from our data set, the value MSA was 5.4. And MLA percent expansion was 80%. So this is quite similar of the previous recommended value. So what about the IVUS criteria of the left main bifurcation? As you can see, the left main lesions, some 5 different portions. Left main portion and POC and LAD os and circumflex os. So these 4 different portions, they had a different cutoff value. Is circumflex 5.0, the LAD os is 6.3, POC is 7.2, and left main 8. So we easily knows the 5, 6, 7, 8. So the patient, when we compare the clinical outcomes according to the under expansion or not, based on these cutoff values, definitely MACE rate is significantly higher lesion with under expansion. So stent optimization would be the key for the clinical outcome after complex PCI. So how to improve stent optimization? Before that, we should know some predictor for the non-optimization. Even though we perform the IVUS guidance in the lesion of complex lesion, some lesions is definitely difficult to attain of the optimizations. The previous 4 composite study of the 4 RCT is a predictor for non-optimization. Was the first one is age. So old age very difficult to obtain the stent optimization, and long lesion length. The lesion length about 39 millimeters is a difficult to optimization predictor. The third one is a stent diameter. Is a small vessel stent diameter is one of the significant predictor for stent optimization. So based on the AZ and also is lesion length is definitely the lesion. All the age, small vessel long lesion is the most significant predictor for the non-optimization. In this graph is optimization rate of this group is all the age, small vessel long lesions. Is the optimization rate is less than 10%, even with the IVUS guidance. So we should know this group and always occur the non-optimization. So if that, what about the way to obtain a better stent expansion effectively during the complex PCIs? So we investigated a lot of pre-stenting IVUS evaluation on the clinical procedure and clinical outcomes. In this analysis, is a pre-stent IVUS group showed a significantly greater MLD and MSA. And interestingly, the H response also is significantly different. The reason with the pre-stenting IVUS group, the dissection rate is a little bit lower as compared to the reason with the post-stent only IVUS group. So this is the last slide for this lecture. So what about the optimal stent technique for the complex lesion? Some medical centers evaluated the role of intracoronary image-guided pre-dilation, stent sizing, and post-dilation is IPSP is introduced previously in the era of the BLS. In this study is a lesion or patient with IPSP is definitely showed a lower event rate as compared to the non-IPSP group. So for the treatment of the complex lesions, definitely lesion evaluation by IVUS, and also based on the IVUS findings, the stent size selection, and then the stent outcome should be evaluated. So this is the last question, is angiographic optimization always predict the stent optimization on IVUS? From the 4 RCT comparing IVUS angiographic guidance is a patient with the enrolled. Of these, is 80% met the angiographic criteria optimization. However, even despite angiographic attainment, about 40% patients did not obtain imaging optimization, and there was a significant difference outcome. It means the attainment of angiographic outcome or angiographic optimization is easy, but difficult to improve clinical performance just by meeting the angiographic optimization without IVUS guidance. Ladies and gentlemen, this is my conclusion. Many clinical studies prove the superiority of the IVUS-guided PCI in complex lesion, improving opposition, expansion, and can evaluate the complication and remnant plaque, and also stent optimization would be the main determinant for the improvement of the clinical outcome of the complex lesion. So and also the pre-stenting IVUS evaluation and IVUS-guided pre-dilation, stent sizing, and post-dilation, and proper lesion preparation in calcified lesion by rotablation or intravascular lithotripsy would be essential. Thank you for your attention.